Hello, this is a quick video about Parkinson's disease. Parkinson's disease is normally characterized by um, movement disorders like slow movement, tremor, and it's thought to be the result of depleted dopamine in the brain. Basically, the substantia nigra cells in the midbrain is where dopamine is stored and the brain uses for reward and movement. So when there's Parkinson's disease, there's lack of dopamine containing cells in the brain, resulting in the movement disorders, which include bradykinesia or slow movement, shuffling gait, tremor, and some psychiatric disorders as well. And the treatment for Parkinson's disease, like levodopa, is associated with causing some dyskinesias or involuntary muscle movement as well. So treatment for Parkinson's disease include at early stage L-DOPA or levodopa given with peripheral um, enzyme inhibitors, which basically inhibit the conversion of levodopa um, into dopamine on the periphery or the metabolism. So basically, carbidopa or benserizine is given with levodopa in its standard release. Also, the monoamine B inhibitors like rosagiline or selagiline or dopamine agonists like pramipexole or ropinirole are all first-line treatments. So you could give dopamine agonist or monoamine B inhibitors or levodopa depending on patient characteristics. At late stage Parkinson's disease, so this disease is basically a progressive, so as you lost the dopamine containing cells the disease gets worse, and so L-DOPA with catechol O-methyltransferase inhibitors are used like entacapone plus dopamine agonist and the monoamine B inhibitors with the off phenomena, which basically levodopa works optimally at some time, but at times the basically stops working, so the patient can't walk, can't turn in their beds. So for this off symptom, you use the dopamine agonist and low dose levodopa or the monoamine B oxidase inhibitors. Also, amantadine, which is weak dopamine agonist, is used sometimes. Also, antimuscarinics like orphanidine or trihexyphenidyl um, is sometimes used to reduce the central cholinergic excess or increased acetylcholine, which happens when there's depleted dopamine in the brain. There's also this medicine which is called apomorphine, which is a very potent dopamine inhibitor. So this is usually used for off symptoms, as we'll see later. There are also some dopamine agonists, which are argot-derived alkaloids like promocroptine, but these are very rarely used in Parkinson's disease because of the risk of fibrotic reactions, um, especially lung fibrosis and hepatic fibrosis as well. So, as we said, the side effects include fibrosis, where basically you lose um, the functional cells in the lungs. There's also hypotension with all dopamine agonists, and also impulse control disorders where the person engages in risky behavior like hypersexuality or binge eating, um, where the person just want it now. There's also the sudden onset sleepiness with all dopamine agonists. So you need to educate patients to be aware of symptoms of drowsiness if someone drives a car or is engaged with very dangerous machinery. Um, there's also the relationship between antipsychotics and anti-Parkinson's disease. So basically, antipsychotics, if you remember, block dopamine, and then Parkinson's disease increases. Drugs for anti-Parkinson's disease increase the concentration of dopamine. So anti-Parkinson's drugs might worsen psychosis, and antipsychotic drugs might worsen Parkinson's disease because antipsychotics, if you remember, associated with Parkinsonism, symptoms like tardive dyskinesia, tremor, dystonias with abnormal facial appearances or restlessness. So there's this relationship between these two classes of drugs. And if you remember drug interactions, be aware of monoamine oxidase inhibitors, so selagelin and rosagelin. Monoamine B inhibitors, so do not use with antidepressants. And so you need to avoid monoamine oxidase inhibitors with selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors like duloxetine or venlafaxine, tricyclic antidepressants. Also, estrogens and progestogens inhibit the increase the concentration of monoamine oxidase inhibitors, so they inhibit the enzyme which metabolizes monoamine oxidase inhibitors. So do not use these hormones. Also, be aware of over-the-counter decongestants like pseudoephedrine, ephedrine, oxymetazoline, which is usually used for nasal congestion. Um, and dextromethorphan as well, which is an opioid. Drug used for dry cough. And as we said, apomorphine is a potent dopamine agonist. So patients use it like insulin pens. So they increase the dose of apomorphine when they think specialists basically titrate the dose of apomorphine at first, and then patients are taught how to administer the apomorphine for the off symptoms when levodopa stops to work. As we said, this causes severe hypertension, so patients need to be aware of if they develop any side effects to stop using apomorphine.